Greetings, everyone, and welcome to the EKG case for the week of May 20th, 2013. We've got a great case for you today. In fact, the only way I can describe this case is to say that it is incredibly impressive. There's no better word than impressive to describe this case. And this impressive case was sent to us all the way from Ireland by Dr. Andy Neal, who I've kind of gotten to know through Twitter, and many of you out there that are involved in Twitter will probably know Andy. He is an emergency physician in Ireland who one day had this 50-year-old man that presented to the emergency department with an inability to move his arms or his legs bilaterally. So I guess if you're thinking the worst case scenario, if this were a stroke, it would probably be, I guess, a basilar artery stroke, which is about the worst kind of stroke you can possibly have in order for it to be bilateral, since most strokes, of course, are unilateral. And I don't honestly know whether this guy was completely paralyzed or he just had such profound weakness that he came in saying that he couldn't move his arms or legs. But anyway, you're certainly worried about some type of neurologic abnormality, basilar artery stroke, or maybe a spinal cord problem. Who knows? Well, with a little history, I'm going to give you a big hint here. This guy has a history of renal problems, and he is due for dialysis later that day. I don't think he's missed dialysis, but anyway, he's due for dialysis. And of course, that's always a big hint because, you know, if you see a renal patient in the emergency department who simply sneezes the wrong way, you're going to think about hyperkalemia. You've got to think about hyperkalemia in any ED patient who's got a history of renal failure. And so we're going to get a 12-lead EKG. And besides, frankly, well, this is an EKG video series, right? So we're going to start out by getting a 12-lead EKG. But let's pretend for just a moment that this were not an EKG video series. Would you get an EKG on a person with just this history? I don't know that I would. But certainly with the history of renal failure, you've got to think about hyperkalemia. You've got to think about metabolic abnormalities, whether it's hypokalemia, phosphate problems, whatever. You're going to get a 12-lead EKG pretty early and think about metabolic problems. So we're going to get the 12-lead EKG, and here it is. And it's clearly abnormal. Now, many of you out there probably got the diagnosis in 2 seconds flat. We're going to talk about what the diagnosis here. Let's actually just go through the rhythm for formality's sake. It's kind of a bizarre rhythm, isn't it? And one of the things that we've said before, I think, is that when the word bizarre pops into your head as you look at a 12-lead EKG, bizarre because the rhythm doesn't really seem to make sense or the QRS complexes are just a little odd-looking, bizarre in emergency medicine equals calcium and sodium bicarbonate. And you probably throw some insulin in there also. But calcium and sodium bicarbonate I like to start out with only because they really are not harmful in the majority of patients if it turns out not to be a potassium problem. So anyway, sorry, we're digressing here. Let's go through the rhythm. You really don't see any good P waves anywhere. There's a P wave right there, maybe, but there's a lot of artifacts. I'm just going to scratch that out. Don't look at that lead. All the rest of the leads and complexes, you really don't see any good P waves. So I wouldn't call this a sinus rhythm. The QRS complexes are really wide. And we've talked before about the significance of really wide QRS complexes. What we said before, for those people that don't remember, when the QRS complex is greater than 1 full box wide, you've always got to think about tox and metabolic problems. Okay, and of course, this is a renal patient, so we're thinking about that already. But we've got a wide complex rhythm. The rate here is not fast. It's probably in the 60s or 70s or so. It's a really wide and somewhat bizarre looking QRS complexes. There's very tall T waves, and there's a lot of things, hopefully, that are jumping out at you, making you think about hyperkalemia. You'll also notice that there's almost kind of like a Brugada, let me get rid of this, almost like a Brugada type of pattern in V1 and V2. Hyperkalemia is well known to mimic a Brugada type of pattern with a right bundle or incomplete right bundle pattern with ST segment elevation in V1 and V2. Hyperkalemia is known to produce changes in the axis. This patient's got a leftward axis. It's known to imitate right bundle branch block patterns or left bundle branch block patterns. It can give you fascicular blocks, brachydysrhythmias, tachydysrhythmias. It can do anything to the 12-lead EKG. And that's why I refer to hyperkalemia as the syphilis of electrocardiography, the great imitator of electrocardiography. Well, in this case, apparently it seems to imitate many other medical conditions, not just on EKG, but clinical scenarios as well. So we get a 12. We're going to come back to some of the specific findings, and one finding in particular I want to point out in just a little bit. But we get a potassium level, and no surprise, 10.2. Well, maybe it is a surprise because 10.2 doesn't seem compatible with life. This patient is approaching a terminal stage. 10.2. We better do something about this quickly. And Andy jumped all over this, gave the patient some calcium and probably a handful of other measures for hyperkalemia and saved this guy's life. Once again, a piece of paper and ink gives you information that saves the patient's life. Well done, Dr. Neal, to save this patient's life. And what do you know? This guy's stroke resolved even without thrombolytics. Go figure. Thrombolytics were not the answer in this particular case. So anyway, this is a very interesting entity that I hadn't heard of before Dr. Neal brought this up. This is something called hyperkalemic paralysis, and I'm going to digress to talk about the clinical condition for just a second, also known as impressive syndrome. That's why I said this is one of the most impressive cases I've come across in a long time. So real quickly, what is hyperkalemic paralysis? It's rare. You're probably not going to see this during the course of your career, and this is probably the only case that Dr. Neal will see during his career unless this patient comes back again. But this is an autosomal dominant condition which affects the sodium channels, and I know many of the tox people out there are probably salivating as we talk about sodium channels. And I consulted Dr. Wikipedia to get this information, by the way, and I don't know anything about sodium channels except that they are important, and when they're screwed up, you can develop all kinds of bad things on the 12-lead EKG. And clinically, you can get muscle weakness, paralysis, and if you paralyze your diaphragm, well, you're going to die. And patients can actually die from this as well, and you end up with potassium problems in the serum. What's interesting about this is that it rarely affects humans, but about 1 in 50 quarter horses will be affected. So it's a bit more known in the horse racing field, I guess. Quarter horses are horses that are named quarter horses because they're well known for their sprinting ability at the quarter mile. And this is another interesting thing from Wikipedia. With the horses, these cases can be traced to a single ancestor, a stallion by the name of impressive, and that's why it's called impressive syndrome. Now, I don't know how this went from horses to humans. I don't even want to think about how this may have happened, or with this patient, how it ended up in his family tree. But anyway, perhaps that's politically incorrect. But you gotta wonder. Anyway, let's keep moving on. So that's a clinical condition or a very impressive thing. I've heard of hypokalemic paralysis, but never before this case hyperkalemic paralysis. So there you have it. Okay, let's go back to the 12-lead EKG. And there's one other thing I want to point out. I think most everybody, would pick up hyperkalemia, certainly from the very tall T waves there. But I do want to point out that hyperkalemia can produce ST segment elevation, and oftentimes the computer will call this STEMI. Oftentimes, in this particular case, I would not be surprised if the computer called this a septal STEMI. I've never seen a computer interpretation diagnose hyperkalemia. For whatever reason, computers are not programmed to read out hyperkalemia, and hopefully everyone out there says this is hyperkalemia, but if you're not careful, you may go with the computer interpretation that could call this a STEMI. So hyperkalemia, the great imitator, the syphilis, can produce ST elevation and mimic STEMIs if you don't recognize the T waves up there. Well, the one other clue that I wanted to point out, which I don't know of anybody who's ever talked about this before except Henry Marriott, one of the real EKG gurus in the history of electrocardiography. And I think I've purchased and read just about everything I've ever seen Marriott's name on. It's a brilliant cardiologist, electrocardiographer. One of the things he talked about in hyperkalemic wide complex rhythms is that the QRS complexes take on an appearance of almost like a weight dropped right on the upsloping part of the ST segment, so it sags. Essentially, you've got the QRS coming down, and then instead of going up, it kind of slants off like this, almost as if there's a weight sitting right there, pushing that ST segment off to the side. You won't see that in all of the leads, but typically in the inferior and oftentimes in the lateral leads, you get this, the upsloping part of the S wave goes outwards instead of going straight up. And when you see that type of appearance, it's a very nice clue that you're dealing with severe hyperkalemia. Here's another example. This is from my collection. Potassium was 8.3. You see a new huge right bundle-ish type of block up there. And again, you see that ST segment sagging, almost like there's something sitting right there on that ST segment, pushing it out. And maybe I'm drawing the arrows the wrong way because I should be drawing them out that way, like the ST segment's being pushed out that way because there's a weight sitting right on top of it, right? And here's yet one more example. And this patient actually was read by the computer as having a septal STEMI because of this ST elevation up here. And if you look at this, there's very clear-cut peaking of the T waves up there. This patient actually had diabetic ketoacidosis, and one of the things I sent out on Twitter is that the fastest killer of a patient with DKA is hyperkalemia, and this patient was so acidotic that even though they were total body potassium depleted, their serum potassium was in the 8s, and then rapidly dropped. But I've seen a couple of patients actually die from hyperkalemia in DKA. So just as an aside, the first test you get whenever you suspect DKA, hyperglycemia plus a sick-looking patient, get a 12-lead EKG looking for hyperkalemia, and that's exactly what's going on here. This patient had hyperkalemia with DKA. The computer got it wrong, called it a septal STEMI, and there is your ST sagging. The upsloping part of the ST segment is kind of pushed out in some of these leads. And again, that's something that I got to credit Marriott for teaching me about through some of the things that he had written. Anyway, just a few quick take-home points here. Once again, very impressive take-home points, so with that impressive syndrome. So renal patients, any renal patient with the systemic complaint, I'm telling you, if they just look funny, if they cough, if they sneeze in a funny way, get a 12-lead EKG. You're going to save a life. And what happens if it's normal? Well, it's a piece of paper and ink, big deal. But you will save the lives of renal patients if you're liberal about 12-lead EKGs in any renal patient that has any type of systemic complaint. All right, think about hyperkalemia. It is the most rapid killer from a metabolic standpoint. It's the most dangerous electrolyte abnormality, the most rapid killer in DKA, the most rapid killer in sick renal patients. If they have a really wide QRS, really wide, greater than 200 milliseconds, greater than one big box wide. If that QRS is really wide, think toxin metabolic. And when you've got that delayed upstroke, the upsloping part of the S wave goes outwards like that, you think about hyperkalemia. Again, crediting Henry Marriott for that. And again, the most rapid killer in DK is hyperkalemia. So just a few, I think, nice take-home pearls from a very nice case. My thanks again to Andy Neal for sending that case and teaching us all about impressive syndrome. I've never heard of it before. I'll probably never see it again, but, maybe if I do, I will know exactly what to look for, and you will also. So thanks to Dr. Neal, and I will talk to you all next week. Bye for now.